Thanks, Jennifer, and thank you, Ivelisse and Jimmy, for the inspiration and for the honor of being able to speak to all of you. I'm a traditional oncologist. I'm an oncologist here at Johns Hopkins, traditionally trained in the art of treating patients with cancer, with chemotherapy, with traditional ways, surgery, radiation. I see patients at Hopkins, as you can imagine, that come to me after they've failed all traditional therapies, or they're early on in the course of their disease, and their disease is a lethal disease. Ivelisse was one such patient. And all my training to date has been to use the tools that we have to take patients as far as we can possibly go. But all of my patients typically get to a point where traditional therapies fail. And that's why I spend a lot of my time in a basic science lab, surrounded with some of the best and brightest minds, trying to figure out the best way to approach cancer in the future. And we have a few people from the lab here. Yushwin, stand up, she's in the yellow. She's a gene hunter. She's looking for genes responsible for cancer. And she's done amazing things at Johns Hopkins. And Andrew and Jackie, please stand up. They're looking for ways to target these genes in new and different ways. And I'm telling you this to give you a little bit of my background. It's very traditional, it's steeped in very conservative science, and it's very unique for a physician like myself to be approached by a patient to change the way I think. And usually, I'm teaching the patient or educating the patient, and in this case, the patient educated me. And so, why don't I begin with my inspiration? My day job is traditional oncology, and I can tell you at Hopkins, we do it very well. My day job is basic science research with some of the best and brightest minds, and I can tell you we do very well. But we need to do better. Patients are still dying. We are still having many millions of diagnoses of cancer every year. Millions of patients are dying every year, despite all the advances that we're making in the laboratories and in the clinic. And the story with Ivelisse is quite unique. This is a patient who has advanced metastatic colon cancer. That's a lethal diagnosis. And on top of that, she has a strong family history of cancer. So not only does she have a lethal condition, but it's bolstered by the fact that her family has a strong family history of the same cancer. One would think that this patient would take the traditional, most aggressive approach. Patients come see me because I'm known to be a very aggressive oncologist. I treat with very aggressive chemotherapy. But here I have Ivelisse saying, you know what, Dr. Diaz or Luis, I don't want to do chemotherapy. I want to do something different. And that's what turned the tables. It took the relationship from a physician teaching a patient to the patient teaching me. And over the past 5-6 years now, we've, by text message, gotten lab results going back and forth, followed up on CT scans, and thankfully, and probably for reasons that we don't completely understand, probably related to the mistletoe, she's cancer-free today. And that's 5 years out from her initial diagnosis of metastatic disease. So that's the inspiration behind this. And so how do we get from Ivelisse as one patient to Ivelisse being really the catalyst for making this into a clinical trial that could potentially help thousands, even millions of patients? Well, there's a little bit of science behind it. I don't know why. And the science is really mistletoe. What did she do? Well, she took subcutaneous injections of mistletoe, the extract of mistletoe. It caused a little hive under the skin, and that did a number of things, and I've seen this with a number of my patients. I have at least 2 to 3 dozen patients that I share with Peter and people in his clinic, and all of them universally say, you know what, I feel better. And not only do they feel better, but they require less anti-nausea medication. They're less tired. You hear about them shoveling snow on chemotherapy or gardening on chemotherapy. And this is not new. We've known this for hundreds of years, but it's new to this country. And it needs to be tested in a very formal fashion. What do we think it does? Well, it's been used extensively in Europe. It's been shown to have some anti-tumor activity, but we really can't put our finger on it. It works in some situations. It doesn't work in other situations. It has to be studied properly. And I can tell you one thing we do very well at Johns Hopkins is take apart the mechanism of how something works and figure it out. We've done that for hundreds of years, and we have a long list of natural products like mistletoe that we figured out the mechanism of action and how to employ that in a proper way in the clinic. But back to what we think it does, we do have a sense that it might boost the immune system. It's a lectin. It's a special kind of sugar. And we know that these sugars can stimulate the immune system in a certain type of way, and that may be why patients are feeling better. That may be why we're seeing efficacy like we did with Ivalice. That may be why patients aren't taking the nausea medication like they were in the past. So a lot of promise behind that, but our goal is to study it properly. So what do we have to do to study it properly? In this country and around the world, when you have a new drug, when you have a new compound, it has to be studied properly. And the reason is you don't want to go straight into 1,000-patient clinical studies that will not only be costly, but exposing thousands of people to a potentially toxic drug. There are countless studies like that where the drug was tested in humans and discarded because it was too toxic. Now we know that's not going to be the case with mistletoe because thousands of people have been treated with it. But what we're going to do is start with phase 1, the safety study. And the safety study looks in a very systematic fashion by increasing the dose of mistletoe, what its possible side effects are. And while we're doing that, we're going to be collecting blood samples, we'll be collecting other laboratory values that will give us hints as to how it may be working. Once the phase 1's done, we can move on to phase 2, which is looking for activity. And we'll try this in all tumor types: breast cancer, colon cancer, pancreatic cancer, lung cancer, melanoma, prostate cancer, kidney cancer. And while the phase 1 looks at all patients, all comers, the phase 2s are a little bit more directed. We're looking for any sort of anti-tumor activity in those individual tumor types. And then once you have that information, you pick your best horse, your best combination, and you go to the phase 3. A large clinical trial, typically of hundreds to thousands of patients, where we try to figure out, is this better than our standard of care? Is this going to move the needle in curing patients or making patients live longer? So that's what we need to do to bring mistletoe from where we are today to mainstream use. So what else do we need to do that? Well, the phase 1 study, which is already essentially written, we're waiting for some regulatory hurdles to jump through, is going to be a phase 1 dose escalation study, 20 to 30 patients of all tumor types. We're not going to discriminate by tumor type. We're going to look at everything possible, and it's going to be conducted at Johns Hopkins. And my hope is that we can really see some answers by the end of this year, and we're all very excited about that. But there's something else we need to do. We need to build a team. And I don't know how many of you have been following the NFL draft. You have your first round picks, and I don't remember how Baltimore's done, but I do know that Jay Clowney did pretty well by being our first round draft pick. They have nothing on our team. And I can tell you that Channing Paller, who's here in the audience, is the individual who will be the principal investigator of the study. So what does that mean? She will run this study day in and day out with all of our support, but she's an expert at this level of study. And as you can see, she's gone through a selection process just as hard as these NFL football players, and they'd be lucky to have her. Harvard Med School, then selected in a process much like the NFL draft to be a resident at Johns Hopkins. It is a ranking system, and it's equally as cutthroat, and then fellowship at Johns Hopkins, and now she's a faculty member here at Johns Hopkins. And so we have selected somebody who's not only very talented, but very motivated, because she's dedicating her life to complementary and alternative medicines and using that in medicine. I think you wanted to say a quick word. Do you want to pop up here?
Thank you, Louise, and thank you, Evilise. So a little fact, despite my history, is since I was a child, I dreamed of merging Eastern and Western medicine, embracing that complementary approach that Evilise discussed, and Believe Big has made that possible for me. So it is an honor to be part of this research team, and I'm really excited to start this clinical trial. So if any of you have questions afterwards, I'm here to answer them.
First round draft pick. First round draft pick. So you've heard a little bit about my background, why we at Hopkins have chosen to pursue this avenue, this very important avenue of research. You've heard a little bit about the story about Evilise and how she really changed my approach in thinking about mistletoe and alternative therapies. You've heard about the science and what we need to do to get past a phase 1 study, and you've heard about Channing, who's our first round draft pick. But what about the future? Well, the future I've mentioned a little bit, but it's really about taking mistletoe, once we establish a safe and effective dose to use it at, and trying it in as many different type of combinations and in different manners as possible to find the niche where it's going to make the biggest impact. Because right now, we as a collective team have to focus our energies in getting this as far as we possibly can, because we know it works. We just have to understand how it works in the best possible way and begin to break apart how we think it works and apply it in the best possible situations. So I'm going to stop there. Thank you for listening, and thank you for being part of this. I appreciate it.